All right, so this is not my worst complication, but it's a good one to discuss still. And the basic message is going to be resist the temptation to do a quick case, because we've all been there. This is a man who, 67-year-old man with all the risk factors, end-stage renal disease on hemodialysis, presents with non-STEMI to our county hospital, has a mild LV systolic dysfunction, and gets diagnostic angiography by my partner. He gets taken off the table. You can see the severe disease involving the proximal vessels of the left coronary system. Severe calcification, you can appreciate. Gets taken off the table, and there's discussion about surgical revascularization. After several discussions, it is decided that the surgeon does not want to operate on this patient. There are multiple comorbidities, and they just do not want to. So we accept him for PCI, and unfortunately, he got added on after a busy day. Multiple outpatients, other inpatients, and then me, not having known him before, gets handed this gem at the end of the day. And so we get going. And so plan was to use a large guide. So we have an 8 French XP35 here in the left main, wire both vessels, and we work on the LAD first. And you can see very resistant lesion here. So I'll ask up front, would everyone atherectomize this patient even before ballooning? It's probably yes. I mean, that's I think the correct answer, right? Again, we were trying to rush through this, and we did not do that. And so you can see resistant waste on this non-compliant balloon at high pressure. And still, we made the decision not to proceed with atherectomy after that. And that was the critical mistake. And it's about wanting to rush, finish the case, let's go, we need to get out of here. And that's the mistake. So here is an important thing. So we inflate the cutting balloon up to about 25 atts. And I see this, and no one in the room is reacting. And so when you see this and you know what happened, you need to react very quickly, because the balloon has ruptured. You can't use this balloon to occlude, and you know that the contrast is now outside the vessel, is going to move quickly. And so you need to extract this balloon quickly and implant a balloon to occlude the likely perforation that you have. To prove it, obviously you do this. So this is what we're dealing with. Complex rupture of the LAD. You can see the pericardium fill up there. You do not have much time here, and so you need to implant a balloon quickly. And so this is what we did. We got a 3.0 by 15 semi-compliant balloon, inflated this. The mistake here is to reverse the patient. And so you can get away with sealing these up, a lot of them, even Ellis type 3 perforations by balloon occluding. But the mistake is to reverse this patient, because then you will be dealing with clot filling the vessel and infarction. And so do not reverse. Occlude, make sure you're sealed up, immediately call for help. So echo is going to be your first thing. Make sure you have your pericardiocentesis tray available. And so with sealing him up and prolonged balloon inflations, he actually just had a small pericardial fusion. We moved quickly enough to avoid even a tap in him. And how I handle this is not just leaving it inflated for several minutes. You want blood to exit the ruptured segment so that the clotting begins to tampen out the vessel from the outside. And so just transiently, you want some blood flow to go down the vessel. So after several minutes of balloon inflation, I would deflate the balloon, let some flow go, and then reinflate the balloon. And I do this process over and over. Again, that also avoids clot from forming down the vessel when you have prolonged balloon inflations. And so this is after several minutes of doing this process over and over and over and over and over. You can see that there's some sealing there. So what would people do in this scenario? I'll open up to the panel real quick.
Just one quick thing before you go to that.
Yeah.
The other technique to maintain flow in the LAD, Manos actually published this, his meeting, so I'm going to talk about it,
Yep.
is that you can take a microcatheter down into the mid-LAD and then inflate the balloon to seal the perf, and through the microcatheter just inject blood. And so it's like a perfusion balloon.
Yeah.
Vascular Solutions is apparently going to come out with a newer version of the perfusion balloon, but until that actually happens, or Teleflex, you can use that technique and maintain flow while you're up.
Absolutely.
Yeah, it'd be tempting to stop and bring him back. You mean as far as do you go on and
Right,
stent now?
yeah,
'Cause
what do
you
we
have
do?
not
Yeah.
put a stent in
Yeah.
so far, but I think it's a great case of sealing it with a long inflation. And the only other thing I'd say is I agree with you on not reversing, but if you ever, even one level higher than that is don't reverse when you have gear in.
Yes.
Because that's almost a
Absolutely.
guaranteed disaster if you have, it really makes you thrombose.
Yeah.
I think one of your concerns is you have, a mechanical trauma there, and whatever definitive therapy for that is going to create more mechanical trauma. And so if you sealed it, you could tear that again, and I think you run the risk of, if you put a bare metal stent there or a DES, you may open that up again. If you put a covered stent, then you have a covered stent in the mid LAD. That's not attractive either. So there is a lot of urging here to leave that be for now, to let that heal up, since he's got flow distally, and he had a lesion there to begin with. But that's the concerns about manipulating it more.
Yeah, so we decided to take him off the table, asked the surgeons to reevaluate him for bypass, and they rejected. Not surprisingly. And so we kept him in the unit, did surveillance echoes. He had no effusion. We never had to tap him. But he continued having angina, enzymes rose, that sort of situation. And so they twisted our arms to bring him back to the lab and intervene on him. And so we ended up doing this. And so on the left-hand side, 3 days later, you can see the angiogram, and you can see a little pocket of pseudoaneurysm on top of the LAD at the site of rupture. And so I didn't like the idea of implanting a covered stent in this LAD with that type of disease and setting him up for restenosis for sure. And so I elected to leave the pseudoaneurysm and just treat him with drug-eluting stent implantation. We did bifurcation with the circumflex into the left main a bit, and got this result. And watched him on the table for a little bit and did a final angiogram about 10, 15 minutes after, and it was pretty stable. We felt comfortable that this would continue to be walled off.
That was balloon alone, no atherectomy.
No atherectomy. Yeah, it turns out when you rupture a vessel, it expands nicely.
Yeah, although we have done cases of
Where it doesn't
atherectomy
happen, yeah.
through perf afterwards because nothing would deliver. So
Yeah. So he did well, and 5 months later returns with severe angina, accelerating angina, and you can see he has severe instant restenosis of his circumflex. You would think it would be the LAD that would be the issue, but it's not. But this, I think, shows nicely what these types of pseudoaneurysms can do over time. And although it seems larger, it's more circumscribed, and it seemed to have walled off much nicer. Since he didn't have any significant instant restenosis of his LAD, we left that alone, just treated his circumflex, and sent him on his merry way. 11 months later, he returns with non-STEMI, and you can see the theme here. It's the circumflex is the issue over and over and over. So he was pretty sick with this, but you can see on the right-hand side that the pseudoaneurysm, the LAD, has diminished in size. It started to thrombose off completely, and so we were happy about that. Treated his circumflex, and then 4 months later comes back with another MI, bradycardia and VT arrest before he comes to the cath lab. My partner did this case, and you can see temp wire in place. He was pretty sick at this point. He interpreted this as clot in the circumflex stent that was placed 4 months prior. But he was sicker this time. You can see that the Prox LAD stent has now restenosed to a significant degree, and I think that was causing more problems for him. But the point of this is that the pseudoaneurysm had walled off completely, almost completely here. Unfortunately, he did not make it out of this hospitalization, died just from circulatory problems, even though they got successful revascularization here. Just too much of a systemic insult for him. So lessons learned, go to atherectomy early. When you think about it, do it. That's the basic thing here. Resist the temptation to do quick cases because they become worse situations. And then the lesson that not all type 3 perforations require covered stent implantation. The question is whether surveillance imaging is indicated in these types that you're treating medically. And I think for larger ones, and I mean surveillance imaging with cardiac CT, I think larger ones like this is a CTO gone awry that was transferred in shock after perforation into our center. We got him through, and then he was left with this after recovery. And so obviously he almost died with his CTO intervention. He did not want to go back to the cath lab. And so I have followed him over the last year with cardiac CT and just making sure that the size of the pseudoaneurysm isn't growing, because then I would push for covered stent implantation in that scenario. That's about it.
Great.
This is a good example. I don't know if it would change anything, is to have combined conferences with cardiothoracic surgery, and we do that routinely, not for structural, just for coronary cases. I don't know if it would change anything, but I think it's good to share these cases and see what the end result, because a lot of patients, for right reasons get turned down for comorbidities or whatnot, but we've found it helpful to review these type of cases, and sometimes it has changed their opinion on cases, and patients have gone to the OR.
Yeah, I think so. And when you discuss them in real cases that you and the surgeon were involved with, and not in some abstract format, I think it is helpful, and I think it can change their minds.
Any other questions from the audience? Questions to the panel? Well, so let me ask you this. So when do you know that it's okay not to stent? Sometimes they'll seal, if there's a flap there, it'll seal with just a drug-eluting stent, and maybe that help. So how do you, any thoughts, how do you know that? Because that's the most challenging thing, is to make that call, right?
Yeah, I don't think there's an easy way to know it. This case seemed more straightforward to me to leave it alone. I think a lot of cases we might go ahead and seal, especially if we think there's a lot of, maybe we might just seal the perforation with the stent, but a lot of it gets back to judgment, and sometimes being conservative is, on this case, a good idea.
One of the key things is definitely don't leave the lab. This patient, if you're leaving it alone, you got to sit in the lab for like an hour, more, maybe more, serial echoes. If you're worried, right heart cath, some way to figure this out, because invariably these cases, you may be fine. They go to the holding area and then they're hypotensive. Yeah. And you don't know it's because their sympathetics are relaxing, because they're bleeding, or what the heck's going on. So it's just a challenge that way. Also, the time of day impacts things too. So, if it's in the morning, you're more apt to sort of observe it. If it's in the evening, then you're more apt to tap or have other hands on deck to know what's going on. There's a question over here.
Yes, correct.
So do you think, you sort of made the argument that you should have gone rapid straight up. On the other hand, perforation with cutting balloons, unless it's oversized or being too aggressive, to me it's kind of a 6 or 1 half dozen the other in terms of potential for getting yourself in kind of trouble.
Yeah, I think the mechanism of perforation is device perforation. So the actual hydraulic force of the material of the balloon rupturing is what I think caused vessel rupture. That could happen with cutting balloon or with a regular balloon, and so I think not having done that in this calcified of a vessel is the correct thing.
It's interesting, and it's one of the reasons why we're doing this trial, the ECLIPSE trial randomization to atherectomy versus balloon, because conventional thinking is that atherectomy is dangerous, right? You're going to cause problems, you're going to get stuck burrs, you're going to perf. But it turns out that if you do balloon on severely calcified lesions, you also can propagate dissections, you can have perforations because it's uncontrolled. And so one of the interesting things about the trials, we'll be able to sort that out in a large number of patients, because I'm not convinced 100% that if you use good technique that one is perhaps more dangerous than the other. It's just both can have issues. It's just you have to know how to control them.
Yeah, Ajay, I'm curious, have you had any, I've used sometimes the chocolate balloon in these cases as well, and it doesn't seem to, you can talk about pillows of air and all the other things, but when you're not wanting to atherectomize, any experience on that as well? Yeah,
all the specialty balloons remains to be seen. They're smaller series or registries. You can focus the force a little bit in some respects. That's why the angiosculpt is used as well. So angiosculpt, chocolate, Wolverine, all are options, non-compliant balloon. Outside the U.S., they have the OPN balloon, which can go up to 45 atmospheres. It has its own indiflator. It's made of Kevlar. And then we'll see when shockwave comes. So calcium is here to stay. It's increasing in prevalence. The type A lesion is kind of like we don't see it anymore, unfortunately. We just have to get better strategies to be able to deal with it.
A tip off that I would offer to think about this is that when you inflated that balloon, there was crest, so that it looked like there was eccentric calcium that wasn't giving. So it seems to me in that setting, cutting balloon is probably not going to make that lower. It's not like it's like concentric fibrotic plaque that will break apart.
Yeah.
So here, a roto will shave just the eccentric
Absolutely.
portion to give you a much better time.
Absolutely, for sure.
And that's the downside of going up bigger and bigger too, is if you have calcium on one wall and nothing, or no calcium on the other wall, you inflate a balloon, what's going to inflate is this wall,
Yeah.
not the calcium.
Exactly. Yep, that's exactly right. Yep.
One method of salvage when you have diffuse hemorrhage in your pericardium and you can control it with interventional technique, we've done it on 2 cases. It has worked is that you auto-transfuse the patient from the pericardiovascular. You get it out and immediately transfuse it to the venous system or blood surgeons.
It's actually really important to be able to do that because otherwise the patient will exsanguinate. The other aspect of the protamine thing is that if you have a large pericardial effusion and you give protamine, you can clot the pericardium, and unless you dry it first, that can be a problem too. So that's one of the reasons why for large perfs we don't typically give protamine in reverse.
Yeah, in our case, we actually hooked a pericardial drain, and we were using basically an aspiration, went right to a 7 French venous sheath. So that's a critical technique to be able to salvage and make sure the patient doesn't get too hypotensive.
And some of the support devices that you use, you have to give heparin with them too. So that may influence your decision making regarding what to use, and that may be why you use the balloon pump instead of an Impella in your case, Drew. But generally speaking, you can get away short periods of time with a left side support device and arterial pressures with just heparin in the flush, in the purge, and not systemic heparin. But if you had to put an RP in, that's a challenge because you got to get the ACT to 250, and to maintain it at that level is an issue.
All right.
Awesome. Well, thanks so much to all the case presenters, panelists, to the audience. This was a really fantastic session. Enjoy the rest of your meeting.